Let me begin with the relapsed setting in CLL and SLL. This was difficult to treat until we had all these novel drugs that became available. Before we had them on hand, we treated most patients with chemoimmunotherapy, also in relapse. And we often used BR instead of FCR, so we changed the chemotherapy backbone.
So that's bendamustine rituximab?
Yes, that was the most commonly used combination, at least in Europe.
Okay, so now you're using Ibrutinib. Now tell me, what is Ibrutinib doing theoretically, and then I'd like to know how you used it.
So Ibrutinib is the first-in-class kinase inhibitor, inhibiting the signal transduction of the B-cell receptor pathway. And it was developed as a single agent first and tested mainly in the relapsed patients. So the idea was now to combine the chemoimmunotherapy with BR with this novel agent, Ibrutinib.
Why did you think CLL would be a good candidate disease in the relapsed refractory setting for this?
Because CLL was one of the major diseases in which Ibrutinib was studied in phase 1 and 2 trials, and Ibrutinib showed excellent efficacy in these patients. And in the relapsed setting, we often had patients who didn't respond well enough to chemoimmunotherapy, so we had a requirement to try something else.
What did you do in the study?
So the Helios study was a phase 3 trial, which was an international trial in 21 countries, and we included almost 600 patients. These patients were randomized, double-blind, to receive either Ibrutinib or placebo combined with bendamustine rituximab.
And what were you looking for? What were your endpoints?
So the primary endpoint of the trial was the progression-free survival. Secondary endpoints were also overall survival, overall response rate, CR rate, MRD, and of course safety.
I gather that you had quite a good response to adding Ibrutinib.
Yes, the primary endpoint, the progression-free survival, was significantly improved. We just recently had the interim analysis, which proved that the addition of Ibrutinib significantly improved the progression-free survival time. After a median observation time of 17 months, the median progression-free survival for the bendamustine rituximab arm was only 13.3 months. And with the addition of Ibrutinib, the median was not yet reached. This was highly statistically significant, and we could see that the risk of progression or death was reduced by 80%.
What are the clinical implications coming out of this?
Well, in addition to this very good response rate and progression-free survival, we also saw this is the second phase 2 trial, that the safety profile with Ibrutinib didn't show any new things. So what we saw in this trial was that the safety was consistent, which was what we expected for bendamustine rituximab and also Ibrutinib. So this trial is very important for us, that we now know that this also is a safe and very efficacious combination.
Well, there is an indication or an approval already for some use of Ibrutinib. In what way does your study enlighten the further clinical use of this drug?
So it shows that it's very efficacious and also safe to use it in the relapsed setting, and also that it is safe to use it in combination with bendamustine rituximab chemoimmunotherapy. So now we have a trial that shows not only that Ibrutinib should be can and should be used as a single agent, but also in combination with chemotherapy and an antibody treatment. So we have 3 principles of treatment taken together.
You say the drug was safe, but were there any new toxicities?
Actually, no. What we saw in this trial was exactly what we expected. Regarding the addition of ibrutinib, we didn't see any cumulative toxicity, no rise in hematological adverse events or infections. What we saw more commonly in the BR ibrutinib arm was atrial fibrillation and bleeding events, which were very rare, and also what we knew before was rash and diarrhea, which were all low grade.
Was there a signal in overall survival?
Well, we see a differentiation of the curves, but so far that's not statistically significant, which is certainly influenced by the fact that a significant number of patients crossed over to receive ibrutinib once they progressed.
What about minimum residual disease?
This is certainly a difference between the two trials. We saw both a higher complete remission rate in patients with ibrutinib added to bendamustine rituximab, and also there was a difference in the MRD rate.
So what's the very brief take-home message for doctors coming out of your study?
So this is the second phase 3 trial with a huge patient population, which showed that the use of ibrutinib combined with bendamustine rituximab chemoimmunotherapy is safe and very efficacious.